Hi, welcome to the Wellness and Prevention section conference breakout session for the 2020 North Carolina Public Health Association Virtual Fall Educational Conference. Our session today is Chasing Prevention, ACEs, Racism, and New Faces. And during our session today, we'll be talking about the link between ACEs and racism and approaches to creating healthy beginnings for all. My name is Lashima Barr, and I'd like to introduce you to my co-presenter.
Hi, I'm Randy Rubenstein. I have a master's in public health from UCLA, and I've held senior level positions in several health organizations. Along the way, I was also a foster parent for 10 children, and it's the combination of my background in work and my children who inspired me to found Educate Tomorrow's Parents. And Educate Tomorrow's Parents is also where I had the great pleasure to meet Lashima Barr.
Thank you, Randy. My background is in biology, and as Randy mentioned, I did spend some time with Educate Tomorrow's Parents as an instructor. Prior to that, I actually worked in Durham as a sixth grade science teacher. I did that through Teach for America for a couple of years. And now I'm working as project coordinator for the ACEs Resilience Initiative here in Raleigh, North Carolina. And I work with a nonprofit, Safe Child, which we work to prevent child abuse and empower families through our parenting programs. And I'll tell you about Safe Child and the ACEs Resilience Initiative a little later on in the presentation. After this webinar, our hope today is that you'll be able to recognize the threat of adverse childhood experiences, or ACEs, to public health. Also, identify ways racial inequities can increase the prevalence of ACEs, and add tactics and tools for engaging new faces, which we identify as partners, diversity, and teens in our community efforts to prevent ACEs. I'm going to turn it back over to Randy to take us into our first objective.
So we're going to begin with a brief description of the ACEs study. And as Lashima has explained, ACEs is an acronym that stands for Adverse Childhood Experiences. And we're just going to give this brief overview because we hope that you'll understand how it's informed the work that Lashima and I have ultimately done in the community and how it can help you in your work. We understand that many of you are probably familiar with ACEs, and we want you to know that we honor your experiences. A lot of times it's our life experiences that bring us to our work, and we would love to hear more about your experiences. We just offer up our work experiences as something that we can all learn from. If you're unfamiliar with the ACEs initiatives, then we hope that you'll have an opportunity to explore the wealth of research that's been done in this area since its beginning. The initial study was published in 1998 by physicians Dr. Felitti and Dr. Anda, and they were studying 17,000 adults, comparing their childhood experiences with their adult health records. So the ACEs area of the adverse childhood experiences was a construct developed by Dr. Felitti, where he was developing like a basket of different types of experiences to understand the relationship between those and adult health and behaviors. He believed that there was probably a connection between those two. And in the ACEs measured, as you can see on this screen, there were 10 different metrics, and everybody would get a score. And for each type of adverse experience, you get a score of 1. People could be scored then from 0, where they had experienced no adverse childhood events, up to 10 if they had childhood where there was a lot of dysfunction with abuse, neglect, and household dysfunction. And then they looked at a number of different outcomes, both in terms of health behavior and their physical and mental health status in adulthood, and went to look at the connection. And the amazing thing is that they found very strong connection, and we'll look at the results now. So the breakthrough findings, the first thing was just landmark finding was that as an ACE score increased, those people had much higher prevalence and rates of different health issues. And they found this across 40 different health issues as of today. We've done so much more research since the initial evaluations, but it's continued to hold through all the research subsequent to this initial study, which this is called a graded dose response relationship. And we've since found that the threshold of having 2 or more ACEs is where the largest impacts are seen. As you can see on the right-hand side of the screen, there's a summary of some of the effects that ACEs have been connected with, from addictions to anxiety, depression, and in fact, heart disease, diabetes, lupus, and even early mortality. The second breakthrough finding was this gap in time, this long-term impact, where things that had occurred decades before were still having an effect on health so many years later. And the third breakthrough finding was that this expanded our understanding of illness etiology. And prior to this study, there was some belief that illness was caused by factors in health behavior or in the way illnesses get communicated in real time. And this now took our understanding to another level, where we began to understand that some of the causal factors might be connected within family environment and could have happened many years prior to the illness appearing. So what's amazing is that these ACE findings are based on a fairly simple measure, where it's only counting if the adversity ever happened, even once. That would count as 1. So it's not looking at the intensity, frequency, or duration of any of these incidents or types. It's just like a question like this one, like, did a parent ever hit you, beat you, kick you, or physically hurt you in any way? And that would count as 1. It's also adversity focused. So it's not looking at whether there's counterbalancing protective factors. And the third thing is it's family focused, looking at childhood experiences. This initial measure didn't look beyond that when it was looking at the ACE score. And so even given all these constraints, it still had a very powerful connection between early childhood experiences and later health. So what do we know about ACE scores today and here in North Carolina? So 1 out of 5 children have experienced 2 or more ACEs. And the impact is that for the children who were studied most recently here in North Carolina, these children have 1.7 times the rate of chronic health conditions and 3.6 times the rate of emotional development and behavioral problems than children with no ACEs. So it's still relevant today, and we're still exploring the depth of the impact of ACEs. And what this looks like in our community is, and we've compiled some statistics for you. So in the first statistic here, we're looking at 3 million children in the United States who are involved in child maltreatment investigations each year. That's just a phenomenal number of children where they're having difficulties in their home that are being reported and investigated. Just want to point out that this number is limited to investigations, and it's actually twice that number for cases that are reported. And who knows how many cases are never reported. So we know that there's just widespread difficulty in our homes for children. And the other statistics are 1 in 4 girls and 1 in 6 boys are sexually abused before age 18. These statistics are very troubling. 65% of all substance abuse treatment clients report experiencing child abuse. 92% of homeless mothers have severe trauma histories. And in a study of juvenile justice settings, 94% of children had experienced trauma. So you can see the profound effect on our public health. ACEs cost our country $80 billion annually in investigation, treatment, chronic health problems, and lost productivity. And for North Carolina, it's about $2.3 billion. Going back up to that last statistic, in a study of the juvenile justice settings, I was struck by this finding here, about 94% children have experienced trauma. For one point that struck me was that the belief that many people hold that children get into trouble because they're not disciplined enough at home and kids are spoiled. And what this number tells you is that's not what's happening for those children. These are not spoiled children. These are children who've been through a lot. And they're probably expressing what's happened to them through behavior, which is getting them in trouble. The other issue that when we look at a number like this is that we begin to realize ACEs is part of the story, but it's not the whole story. Life is more complicated than this, and we live in a social environment. And we know from other research that there's an intersection between racism and racial bias and disparities in what happens in our criminal justice system. And so it's important to understand the intersection between ACEs and these racial issues. And so now I'd like to turn that topic over to Lashima.
Thank you, Randy. And so getting into our next objective, taking this information and what we know about adverse childhood experiences and the profound impact of public health is to think about, well, what are the ways in which racial inequities increase the prevalence of ACEs? And so in order to demonstrate this and talk about this point, I'm actually going to use a framework that I heard, or a question that I heard a couple of years back at an ACEs conference in San Francisco, and a framework from the Milken Institute of Public Health at George Washington University. So back in 2018, I attended the ACEs conference in San Francisco, and there was a session about ACEs in the context of health equity and how ACEs really supports the theory of the idea that racism is indeed a public health issue. And so in that talk, Dr. Flojan Kofer, she stated, she's the research policy director for Public Health Advocates in California, and she posed a question. You know, she said, when we look at the ACEs study, when we look at the information, and it is groundbreaking, the question is, who's missing? You know, when we look at that data and we look at, you know, who was surveyed, her comments were the people in the original ACEs study were disproportionately white, employed and insured, college educated, and middle income. And so, and it's not a criticism of the ACEs study, it is indeed groundbreaking, but it offers us an opportunity to say, okay, well, if these are the circumstances or the issues for those folks that were represented in that study, it begs the question, who are we not thinking about, or who else could we be thinking about? What else could we be thinking about here? And then that brings up the question of what is the intersection when we think about things like systemic and interpersonal racism, how does that show up and how does that impact the prevalence of ACEs in our communities of color? The next framework that I'll be using, or the second part of this that I'll be using to kind of demonstrate this, is this tree that you see here, and it's called the pair of ACEs. And like I said, this comes from the Milken Institute School of Public Health. And this tree, or the pair of ACEs, this image you see here, grew out of the need to illustrate the relationship between adversity within a family and adversity within a community. Because we know that, you know, adverse community environments, which is really the soil in which a family can be implanted in, can really increase or compound those effects of adverse childhood experiences. They can do things like, they really can determine the access that a family might have to care or support when they are experiencing those family challenges. So when you look at this image, again, the soil represents those adverse community environments, and the leaves on the tree you'll see are those 10 categories or 10 areas of adverse childhood experiences, and maternal depression, substance abuse, domestic violence, those things. And so the question is, when we think about it in the lens of racial equity, what does it look like, and what areas, if we were to look at a couple of these areas, and how does racism increase prevalence of ACEs? Before we get into that, I do want to make a couple of definitions. So as we think about what role interpersonal and systemic racism may play, we need to look at what are we talking about. So when I mention interpersonal racism, I'm talking about those directly perceived discriminatory interactions. You know, those biases that can show up when a person goes a place, or those really overt ways of racism between individuals. And this can be in a role, in institutional roles. It can be in, between provider and a client, in the public or, private settings as well, just between community members or residents. And then when we talk about systemic racism, this is that differential access to goods, services, and opportunities by race. And the systemic racism, sometimes is a little bit more subtle because it's so normative. It's the way business has been done all along. And it can be, really insidious because sometimes it's even legalized, and it manifests itself as inherent disadvantages and structural. So much so that it's really codified into our institutions, our customs, or just ways of doing business, our practices, and even law. And overall, systemic racism can manifest itself in both material conditions and access to power. So when we think about those definitions, it really is a good question to think, okay, well, how does that play into what we can see in families and in, the effects and impact of ACEs? So my question, taking these two thoughts, this framework and this question, that Dr. Kofer presented, I learned about a couple of years ago, I looked at, two areas. Let's look at, for example, maternal depression and mental illness. These are both part of the original ACEs study questions that were posed to the participants. And so when we think about that, ways that racial inequity can increase prevalence of ACEs, let's just take, maternal depression. There's a theory called biological weathering, where even before some mothers, Black women become mothers, Black women can experience daily emotional distress of racism, and that is accumulating wear and tear on their health. And then we know that's connected because Black maternal mortality rate is 2.5 times higher than white women. And so in this study shows us that there is some real distress associated with experiences of racism and discrimination, and it actually has a physiological impact on Black women. So when you think about it in the context of the prevalence of ACEs, racism is definitely a contributor. Because of that, those experiences, mothers may experience distress and they may be prone to experiencing depression. So let's say that, we have another, let's keep going with a Black woman who's experiencing mental illness. Racial inequity can increase prevalence and show up in such that it may determine what kind of access to care that a woman might be able to receive if she's experiencing a challenge such as mental illness. So for example, there's a University of Maryland study that when women called providers for mental health services, they were 12% less likely to be offered an appointment if they sounded Black. And so by sounded Black, what that meant was they used, Black sounding names. There was some research done to see, what folks associated is with Black sounding names or language that might be used by, a person of color. So for example, using a name like Lakeisha versus Allison. And these weren't actual individuals, but these were paid actresses, calling to the same places. And so Lakeisha was 12% less likely to get the mental health appointment, to be offered an appointment for mental health services than Allison was. And so when we think about that, where an otherwise healthy individual may be experiencing some challenges and she is really reaching out to go get some help, if there is racial inequity in service providers, whether it's interpersonal or built in just to the process, it really, really can impact how a family or an individual is able to deal with their challenges, and then how that in turn impacts the family. Next, let's think about some more systemic level racism or issues that might show up and how that would look when we're thinking about ACEs. So for example, I'll take one adverse community environment condition, which is discrimination, and we'll look at another ACE, incarceration. So one of the question was that you lived with a family member who had ever been to jail. So now we know, particularly in the social climate that we have today, that there's been a lot of social justice movement around mass incarceration of, Black men or people of color. But then it's not just a social justice issue. It turns into a health equity issue, and it really impacts our families in a real way. So for example, although Black and white people smoke marijuana at similar rates, Black people are 3.7 times more likely to be arrested for marijuana possession. And so that already places our communities of color at greater risk for experiencing ACEs. So let's say you have a family who was otherwise, healthy family, maybe the ACE was 0, but because of some discriminatory practices, there's a family member, possibly a parent or another caretaker, who's incarcerated for something that their white counterparts would not have been incarcerated for. And additionally, University of Pennsylvania Institute for Law and Economics, there was a study that found that Blacks were incarcerated for convicted felony offenses 51% of the time, while whites were convicted of felonies were only incarcerated 38% of the time. So we can see how those, when we talked about how some of those inequities are kind of baked into the system, it could be an unaware bias that individuals might have and they don't know that they're acting on. And it could be, again, just in the policies, we talk about, you hear sometimes in social justice about over-policing of communities of color. So those policies can indeed impact real health issues for families and create circumstances where there might not have been otherwise. A family could have been an otherwise healthy family, but these structural inequities kind of set the table for families to be fragile and put in a very tough situation. So what do we do with all this information? Understanding the heavy impact, the magnitude of the issue when we talk about ACEs and how it impacts health, and other, public health areas, and not just physiological health, when we think about social issues that we're all trying to address. When we think about ACEs in the lens of racial equity and how structural inequities and racism can contribute to greater prevalence of ACEs in communities of color, what does this all mean? We concerned about this information and we care about it because as public health professionals, we are really concerned and passionate about helping our communities and our populations with the things that we carry. And so I like to describe it that way because individuals, whatever way we are trying to address public health issues, individuals show up with a number of things, that they've experienced before they've even gotten to us. It could be the interpersonal and systemic racism. It could be the historical trauma that, shows up, in epigenetics. Or it could be that biological weathering, just the stress of racism. And it could be any of those 10 ACEs, emotional abuse and neglect. And so once we as, professionals are creating interventions or creating prevention plans, there is a lot underneath the surface. It's just the tip of the iceberg. And so when you look at this image here, it's easy to see that what we're seeing on the surface, and you could switch out that behavior, that word behavior, for anything. What we're seeing in individuals, behavior, what we're seeing in, health outcomes, what we're seeing in social issues, there is a lot underneath the surface that could be there. And it's important for us to be aware of how those things impact individuals as we are working on prevention and intervention strategies. So we're going to take a pause here, and we have a video from the Harvard Institute on Developing Child about what it takes to be able to improve child outcomes, and it's a theory of change. And this video we really like because it does a wonderful job of really illustrating for us how all those pieces fit together to make a bigger picture. Those smaller puzzle pieces go together to make a bigger picture. So from ACEs to structural inequities and what it looks like for us to each have our entry points and pull all those pieces together for prevention.
The social challenges that face modern societies, whether it's the ability to work productively, to be a good citizen, stay healthy, have their roots in early health and development. A strong foundation in early childhood results in much better and more effective development later. A weak foundation really puts us behind. The most important thing children need to thrive is to live in an environment of relationships that begins in their family, but also extends out to include adults who aren't family members in child care centers and other programs. What children need is for that entire environment of relationships to be invested in their healthy development. We've shown from decades of testing interventions that we can improve outcomes. But the magnitude of those impacts is not good enough. Science is now available to help us think about what we might do that would have a bigger impact than the best of what we've done before. So we began to ask, what could we be doing differently? What could we do to be smarter? Children who are at the greatest risk for the poorest outcomes in learning and health and behavior are children who experience a pile-up, a cumulative burden of one after another of risk factors. And then the burden is more than any child could be expected to overcome. So we began to focus on the development of the adults. What could we be doing to strengthen the capacity of everyone who interacts with children? This led us to think about the kinds of skills you need to deal with adversity. These skills of focusing attention, planning, monitoring, delaying gratification, being able to solve problems, being able to work in teams, executive function, and self-regulation. They're also the kind of skills you need to create a well-regulated home and school environment in which healthy development and learning can take place. And then brain science started to tell us that differences in those skills start to develop in infancy based on the environment kids live in. So how do those skills get built? Well, if you don't develop them early, how do you develop them later? Actually, you can build them later because the period of flexibility and plasticity for this part of the brain doesn't fully mature until age 25 to 30. And then the light bulb went on. The reason we're not getting a bigger impact is not because we don't know about how to influence development, but because we're giving information and advice to people who we need to do active skill building with. Skill building by coaching, by training, by practice. But we're not doing that. So we now have developed this theory of change that says we need to focus on the development of the adults who are important in kids' lives.
So try this.
How does that work?
That's a new idea.
Buen trabajo.
We need to focus on their skills, their needs, in order for them to be better, more effective parents, in order for them to be better prepared to be employable, which would enhance the economic stability of the family, which is also good for children. Second of all, we looked at many people in preschool programs and child care centers. And we said, what are we doing to build those skills in the providers? They need skill building as well. And also the community can help to build and reinforce the capacities that parents need. And the community also includes programs in which the people who work in the programs have sufficient skills. Third of all, what are the major sources of toxic stress in this community, and how can we reduce them? Moving it up to a policy level, how are our policies strengthening communities' abilities to reduce source of toxic stress and caregivers' abilities to provide what kids need? The development of our human capital is our future. The development of a productive workforce is our future. The development of a healthy population is our future. This kind of future orientation is critical for a healthy society. It's critical for a thriving business. It's critical for a successful environment of relationships to raise children. It's all about being able to plan for the future, to have a future. And that's why this is so important.
I love that video because it does a wonderful job tying all, again, like I said, the pieces together. And I really love the piece about building adult capabilities and not just telling folks to do better. And so this really does a wonderful job of bringing us into our third leg of the presentation today, where we're talking about adding tactics and tools for engaging new faces, engaging partners, making sure there's diversity in our approaches, and also new faces of teams. And this is all in our community efforts to prevent ACEs. So what we're going to do now is share a couple of examples of community efforts in prevention. First, I'm going to talk a little bit more about Safe Child's ACEs of Resilience Initiative, and then Randy's going to come back and talk about Educate Tomorrow's Parents, and we'll be sharing some tips, techniques, and tools that we hope will be helpful to you. Now, Safe Child, which stands for Stop Abuse for Every Child, as I said earlier in my introduction, we support families through child abuse prevention, but not just that, we have a wide range of programs with families because families have a wide range of needs. We annually serve nearly 9,000 children and families through our parenting programs and the Safe Child Advocacy Center. We have programs from that deal with intimate partner violence, supporting moms who maybe deal with, postpartum mood challenges. And then we also are able to we've empowered over 13,000 Wake County first graders through the school-based Funny Tummy Feelings program. And so that teaches children, about how to be able to draw boundaries for themselves and safe boundaries, because we talked about earlier, we shared that statistic about child sexual abuse. So through Funny Tummy's Feelings, first graders are able to identify their own feelings and be able to articulate how they're feeling and express that to the adults around them, and that helps keep them safe. In addition to our programs, we also have 2 community initiatives, and we have the Wake County Child Abuse Prevention Plan, and then the initiative that I coordinate, the ACEs Resilience Initiative. I'm going to take a few moments to tell you just a little bit more about the ACEs Resilience Initiative. So the ACEs Resilience Initiative here in Wake County is a multi-sector, community-driven movement to address and prevent ACEs. And not just prevent ACEs, but also build resilience in Wake County. Now, early on, when we talk about equity earlier and making that connection, early on, initiative members stated the importance of understanding equity and whatever we come up with, whatever work we do in the community, making sure we apply that racial equity lens to our work. And so what the initiative looked like were, it was founded actually back about 2017 in response to, you may have seen the, wonderfully powerful documentary Resilience. So that film was brought to Wake County, and then a lot of our decision makers and leaders within the county saw that film and thought, hey, we have to do something. And so out of that grew this movement, the Resilience Initiative, to address that. And so it was these 4 work groups you see here on the left side of your screen really represents the different sectors that just kept showing up to the table and coming back and saying, hey, we want to be a part of this. And what that, turned out to be were community members. Now, these were folks who may not necessarily have a professional interest in ACEs, but they were, your parents, your grandparents, your community members who this impacted, and they found this a meaningful way to interact with the community and to support the community. And then, there were educators, and there were helpers and providers, and those might have been our service providers, maybe in human services, social services, or healthcare as well. And then we had decision makers and policymakers who also wanted to make sure that they had a voice in addressing this widespread issue of ACEs in our community. So some of the strategies and tactics that we used in addressing ACEs was, one you can see here, increasing community awareness right away. And so what we did was hosted many, resilience film screenings. And so that resulted in over 10,000 Wake County residents being able to view the film. We also were able to start a small lending library. We had purchased a couple of copies of the DVD. And once agencies found out about resilience, so they heard about it, a lot of them wanted to incorporate that into their training for individuals, or bring it back to their churches and bring it back to their volunteer group. And so it really spread like wildfire, if you will, about this movement, and folks wanting to address ACEs and realizing just how important it was to get this information out. And next to that was promoting social norms, and it was really important. And one of the things when we talk about ACEs and the profound impact it has public health and just across our communities, one of the biggest things is to make sure that we address some of the stigma around mental illness and folks being able to say that they need help and it be okay asking for help. And promoting those social norms is also about changing the conversation and, from, oh, well, it's only those type of people who need help, to really it's all of us. We've all had some challenges, right? And so really instilling in our residents here in Wake County to be able to have empathy for one another. And so what that looked like specifically, we were able to partner with churches and communities of color, or just communities in general. And those were either community education events where we may have showed the resilience film, but sometimes it was just a conversation where we came and we talked. And we facilitated some community education events to be able to create that common language. And that was really wonderful because it gave people, it's intuitive for us to know, if bad things happen when, you're little and it's not addressed, it can turn into issues later on. But folks didn't always have the language to describe what that was happening. And so what we saw in the communities was this, aha moment where you'd see the light bulb go off, and it's just like, it made complete sense. And this really motivated, communities to action, to say, oh, well, how can we continue to support, our residents, and let them know it's okay to ask for help. And then it was amazing, some of the stories that folks began to open up and share their own stories. And immediately in that way, it began to, again, create this social norm around everybody needs a little bit of help. It's okay not to be okay. And another powerful piece about that was that it removed some of the blame and stigma around, parents who may be having challenges. It's not that you're a bad parent. Maybe you're dealing with some things, kind of like what Randy said earlier with the juvenile justice study. It's not that these kids are just making horrible choices. Is it possible that they're dealing with some unresolved issues from earlier in life? Or folks are just living in really tough situations. And another one of our strategies is to build organizational capacity. As we saw in the short video, that it's important to think about, okay, not only were we building the adults or parents' capabilities, but it's important to build provider capabilities so that wherever our children and our families are going, that they're hearing the similar language, they're seeing the same kind of culture around resilience, and, understanding what it means to have the resilient community and what it looks like to be prevention minded as well in your organization. And the way we did that, we talked with agencies, organizations a lot about protective factors that look like, very simply just trainings. It looked like organizations bringing in the topic of resilience, whether it be the film or whether it was some other way, addressing it with their staff and making it, a cultural norm that we want to be trauma informed. We want to be trauma responsive. We want to not just be aware, but respond in a way that says that we understand that folks are sometimes showing up to our agencies with some challenges, and how do we best respond that way? So not to further any harm, and to also be a place of healing for individuals. And that happened through toolkits. I will say this is that, and I may talk about this a little bit more when we talk about some lessons learned, is that through this initiative, at the time that we got this going, there wasn't a lot of information. There wasn't a lot of blueprints or how to do this. So it was kind of, sometimes we were building the plane as we were flying. And so it took a lot of, kind of mining for toolkits and saying, okay, well, what's the best information we have here? What's the best available evidence there? And tailoring that, because we had so many different sectors representative at the table, it was sometimes taking mental health information and tailoring it to parks and recreation. What did it look like for educators to share information and services with, non-educators? And so that was really one of the beautiful things about this collaborative as well. And I'll talk a little bit more of that in a minute. And also around, very specifically, building organizational capacity. One concrete thing we did, which came in really handy during this summer, was we hosted Lunch and Learn series on racial equity for our community partners. And this was wonderful. We had decided to do this, before a lot of the social unrest during the summer, but it provided a platform for us to be able to talk about how those real community events and those community situations impact the families and the children that we serve, but also us as providers and as individuals, and how it offered a safe place to go through that information and to process those events in the scope of our work, but also just as individuals. And then through all of this, also one of the strategies was to be able to create some synergy and a community of practice. And so that really happened through building those cross-sector partnerships. And I talked about it just a minute ago when I said it was important to take maybe mental health information that was, just reserved for the folks who did mental health, but then say, okay, what does it look like for us to bring that in different spaces where our focus may not be mental health, but it's important to know those skills and those strategies on how to interact with folks who may be dealing with mental health challenges so that we can better serve our community. So some of the successes, you can read them here. I'm going to talk about just a couple of them. And so one of the ones that is really important to me personally is that our community members began reporting feeling more comfortable talking about tough issues and having empathy for others facing challenges. And that's really important because a lot of times there's that secondary or vicarious trauma that can occur. And sometimes we can, get a little hardened, but it's important to remember, that empathy piece and remember why we care, and to be able to offer others that help when they're facing challenges versus that judgmental tone. Something that was really wonderful also, faith communities began implementing child sexual abuse prevention trainings, resilience ministries, and other community support. So folks got really creative about, okay, what do we do with this information? It's not just enough to say that these bad things are happening and this is horrible, but what are we going to do about it? So we began to see people getting extremely creative about what supports, what social supports, and what it looks like to be able to help the folks around them. And that's when those protective factors really came in handy, because when we framed it with the protective factors, it was like, this is a really big issue and it feels like unwieldy sometimes, but you don't have to do everything. Maybe there's just this one thing that you can do really well. And they were able to see where their entry point for prevention and support might be. Another wonderful success was our opportunity to partner with Wake County Public School System to train over 500 educators, school board members locally and statewide, and staff. You know, we partnered with, one of our wonderful partners was Marbles Kids Museum here in Raleigh, where they hosted our screenings, but they also provided us space to do that training. And I just remember what was amazing about it is that not only teachers showed up for that, but we had bus drivers too, who were there saying, hey, we deal with these children as well, and we see these behaviors, and we deal with the parents, you know, we interact with them, and we want to know what can we do? So it was just really powerful to see that normally folks that you might not assume right away would, you know, want to be involved, or that could be easily overlooked, that they were coming to the table and saying, okay, we have a part of this, and what can we do? Now, there were some lessons learned. There were some wonderful successes, but things that we learned along the way is that racial equity needs to be a part of the process and the outcomes. So in how we set up in how we do business, and how we meet, and where we meet, and when we meet, or just how we do the process of the initiative, equity needs to be a part of that from the outset. And it also needs to be something that we're, you know, working towards in terms of our outcomes. And that kind of goes right into the second point, with nothing for the community without the community. This is something that's really important. And I've seen it done really well out in Edgecombe County with the Rural Opportunity Institute, where they really have the community. And when I say community, I know that as professionals, we're also part of our community. But what about the individuals who are not necessarily professionally involved with this? How are they at the table? Are they part of the decision making? And so that's really important, because it's also a part of the trauma-informed care, you know, principles, is making sure that the folks we serve are also part of the decision-making, so that we sit in our silo and work up with these wonderful things and then go say, hey, what do you think about this? But the folks who know best what they need are the people going through those experiences. And it was really important to ensure alignment with local and state health initiatives or priorities. This was, I don't want to say easy, but it was easy only because of the hard work of the partners who were at the table. Our policymakers worked really tirelessly to make sure that here in Wake County, we aligned with the Population Health Task Force and the Community Health Needs Assessment to see, well, what were the recommendations from those two efforts? And then we align and say, well, if this is important to the Community Health Needs Assessment, then this is what we need to prioritize as well. And so that made it much more effective, and our impact, you know, much more that way, because we are all working in the same direction instead of coming up with brand new individual things to work on. One also major learning was the importance of streamlining partner involvement and having a laser focus on a few goals. And what I mean when I say streamline partner involvement, these are very busy professionals who are coming to the table, who have found it, you know, worth their time and effort to say, well, I have my daily job, I have my, you know, regular 9 to 5, if you will, but this is also important to me. And they saw the alignment in their work, but where do you get the extra time to do the thing? And so what we found is that it's because of, you know, sometimes time capacity, you want to make sure that partners are involved in the way that's meaningful to them, and in a way that works with what they're able to do. And so with that, we now are moving towards a more streamlined structure, where you saw that we had 4 work groups. We've been able to streamline that for more effectiveness and say, okay, we want to work on 2 bucket areas. And so because educators may be also interested in capacity building, but if they're only in the educators group, then they're not really able to work in a way that's meaningful to them. So now we've moved to two goal areas: community outreach and education, and capacity building. So we're also able to offer a little bit more support on implementation piece, because that's another thing that we found, is that toolkits were wonderful and the information was wonderful, but there was some real on the ground, in the weeds support and implementation support and guidance that needed to happen, because a lot of the toolkits that were out there really were professionals writing for other professionals. But when we're trying to get folks who are on the front lines to implement this, it needed to be translated in a way that made sense and was easy, because if you are managing several programs, you don't really have a lot of time to leaf through a 60-page toolkit. And also diversifying strategies and being strength-based. As much as we talk about, and this really want to bring the point of racial equity, as much as we talk about the challenges that communities of color have, we also want to be aware of the inherent resilience and the innate strength in those communities, and not just in communities of colors, but in all individuals as well. And when I talk about diversifying strategies, one thing that we learned is that although we had started off and it was wonderful to show those resilience films, that the community really craved more information. They really desired a deeper understanding and more practical application. And so what we also learned, that it's not enough to, or it's incomplete, I'd say, to just show the film or to talk about these issues that, hey, these are really horrible things happening, and then not offer or pair that with some support or resources. And so one thing that we did in diversifying our strategy was to make sure that there were resources at every film screening. If we did film screenings in the community, make sure that there were resources there that folks could access that day if they needed to. And also make sure that there were mental health professionals paired at the screenings or whatever community event that we had, so that people had an opportunity to reach out for some healing, and if that's what they wanted that day. So I'm going to hand it over now to Randy, and she's going to talk with you about Educate Tomorrow's Parents. And that's because we talk about those really, really big, high-level changes that need to occur, but those changes sometimes take a little bit of time, and we also need those micro interventions or prevention strategies as well. And Educate Tomorrow's Parents is one of those programs that does just that. It's on the ground, working as we work on higher level changes as well. Randy.
So I'm so excited to share with you what we've learned about our program, and through our program working with teens. The mission of our nonprofit was to prevent adverse childhood experiences and to improve child well-being by preparing teens for parenting. And we do that through on-site classes, instructional materials, instructor training. We were founded in 2005, and since that time, we've conducted over 300 programs in both California and North Carolina. It was founded in California. We've instructed over 9,000 teens and instructed over 1,000 professionals and parents. Our work was informed by the ACEs research finding, and as I mentioned earlier, it's very notable that in their metric, it only takes one incident of an adverse experience to count as one ACE, just one incident. So my little mantra is, if ever happened creates an impact, then never happened must be our goal. And to do that means that we have to get really much further upstream to make sure that our children are not being exposed at all, even once, to some of these adverse childhood experiences. And when we look at those different factors in the ACE score, many, if not all of them, originate in the adolescent choices and risks before a family is formed. Next. So in this strategy, the thought is, the best time to prepare for parenting is before conception, because this is the time when teens begin to form relationships and things have a way of snowballing. And so if we start off in good and healthy relationships, it can proceed in that way. Sometimes if the relationships are unhealthy, things can escalate quickly out of control. So we want to help our teens start right out of the gate with healthy relationships This is also a time of risk and experimenting for many teens. And unfortunately, this is also the time when most people may develop addictions for alcohol, drugs, and nicotine. So we want to help them understand, we want to help teens understand the risks involved, not only to themselves, but what they could potentially do to both at the prenatal level and to a future family. And the other reason why it's important to work with teens is it's a great time to develop the capacities before parenting to be able to provide for a child, protect a child, and nurture a child. If they know what's expected going in, then they can start setting the stage for an emerging family. And as you'll see in the diagram on the right on this slide, the way we model this is as teens learn about parenting, then they're able to create healthier emerging families, which in turn reduces ACEs in our population, and we have healthier children. So where does the ETP fit among other approaches? Because some of it may sound a little bit similar. Well, the main thing is that we're intervening before there's even a family, which distinguishes it from a number of other interventions and efforts. So many of people are familiar with, for at-risk families, we try and strengthen them. For when adverse childhood experiences are already evident, social services will intervene or the judicial system will. And post-trauma, we're working to heal a family, to create these healthy families. With our nonprofit, we're, as you can see on from the left side, trying to come in earlier. Next slide. Okay, so to go down a little bit deeper, to be clearer about how we distinguish ourselves from what else is available, is on child abuse prevention. Most of those things are happening after families at risk, and we're there hoping with our program to reach families and make it possible that they don't have risks at all. Parenting education, a lot of the traditional parenting education programs work with pregnant and parenting adults and primarily women. And our hope with Educate Tomorrow's Parents is to make sure we're reaching both males and females, and that we're improving the quality of very early parenting. With maternal health, a lot of health advice is given at the first prenatal visit. But for preconception health, it's so much better to make sure those risks aren't there from day one of conception, whether it's alcoholism or a number of other maternal health issues. Going into it, into pregnancy, it's better to be healthy from the get-go. Family planning, that term usually refers to all the methods to prevent pregnancy. And what we want to do is motivate people to postpone with the understanding that most people are going to go on and have a family. So we think of it in terms of planning for family just later on. And that makes a lot more sense to teens who are looking at their full scope of life events. The school programs that are available in the traditional approach are elective family science classes. So some subset of students can elect to take those, and it's primarily female students. With our approach with ETP, we like to go into health education classes, which are usually required by all students prior to graduation. So you're reaching every student, and so students who didn't even know that they'd have an interest in this, and in particular engage young men in this as well. Next slide. So the tactics for educating teens, we were found that the best way to reach the broad population is through education. So so instead of going into after-school programs or at-home programs, being in a school is an optimal setting, and it's timely, especially in the freshman year when health education or healthful living courses are taught. And we can, as I mentioned, include this broad range of the population, males and females. The way we've designed the program is to begin with a motivational interviewing approach, which is the teens identify their personal goals. And these goals are tremendously different from one teen to another. But this creates their context for learning and future decision making. So they fall in love with their dreams, is essentially what's happening. And in our program, we have several components. The workbook is something they get to keep, reference later. It's their place to hold on to all their ideas. And then we also have slides where we contain the science, and we can keep that updated with statistics and medical knowledge, health knowledge, even family law. And then we have props and make it very interactive, discussion, videos, role play, and different activities. It's culturally sensitive. By being using motivational interviewing, we're able for students to build upon their own expectations and reference points, so their goals and dreams are unique to them. And we found this very helpful in working with different groups about what their expectations for future life will look like in their particular family situation. We've also designed it to be accessible to students for all learning capabilities. They're able to draw responses in pictures, or they can write in words. We want to make it very easy for them. And we designed it for flexible implementation so that it can be scaled for more or less time, and it meets essential standards for secondary schools and health education. This makes it much easier to integrate it into schools. The topics we cover include their life goals, the healthy relationships, preconception health, fatherhood roles, family budgets, which surprised us because that actually became a very important topic when kids began to understand how much it would cost to live in their dream home in their desired way. They're more motivated to want to wait until they can have that dream and figure out how to achieve that. Child safety, child abuse prevention, nurturing growth, and work on positive parenting techniques, because we all know that kids need boundaries set, and some teens have not experienced what positive parenting looks like. So we'd like to have them know what the different tools are. So the overarching goal with this program is to be both a way for them to build those parenting capacities, and as Lashima had mentioned about building skills and helping people know how to expand their repertoire of tools for working with their family and building a family, giving them more knowledge, resources, helping them know where resources are, and build on their personal experience through practice. And in our program, we also have them think through different scenarios so that they have an opportunity before they're put to the test of how to handle a situation. They can think through all the different options and ways to handle it. We're also working on the other side of trying to prevent the triple threat of poverty, mental health, and substance abuse. So when they understand that you can have all these wonderful parenting capacities, but these other issues can undermine your capabilities, and they'll be more motivated to prevent them. So I'm happy to share with you some of the information that we've had about the impact. And for every program we've had, we've measured and surveyed the students to find out in a quantitative way. This is just one of the 6 questions we ask, but one of the questions was, as a result of this program, do you feel better able to provide, protect, and nurture a child? And as you can see, this was 97% agreed, only 3% no effect, and nobody disagreed. And this surprised me from the get-go. When I began collecting data, I expected most teens to say, oh, I knew all this already, I'm fine. But students found great value in the program. And the other thing that we do is collect qualitative data about asking the students also on these surveys about what they liked, what they learned, what they're would they recommend the program, and this other question about what do they plan to do differently as a result of the program. So you'll see in these teens' handwriting some of the things that they're saying, which are just profound about it, that it's really impacting them in so many ways, but they're really committing to learn more and be a very effective parent. They really have already fallen in love with the children they haven't quite conceived yet. Next slide. So the lessons learned. We're really delighted to discover that teens can learn how to form strong families from the start and prevent the circumstances that lead to ACEs. In our new faces, what we're seeing is that it's also possible to partner with schools to do broad-based prevention. So we're happy to encourage everyone in the public health arena to find ways to work with the schools. It's the best place when you're trying to inform and educate teens to get their attention and get their buy-in. And they're really very happy to learn how they can live well. And the other thing that we were delighted to discover is that teens are ready and eager to learn with males as much as females about what it means to be a good parent and how they can start preparing now. The immediate benefits that kind of surprised us, since we were trying to help them plan ahead for the future, is that teens were bringing this information home because some of them have younger siblings or doing childcare. So we were hearing back from our teens that they were sharing these ideas with their parents or helping to care and intervene to protect children when they saw that they were in danger. And this was just a wonderful revelation. We also have been able to identify teens and families needing immediate assistance in some of their replies in the workbook and thinking about what they'd want to do different. Sometimes teens are surfacing very dangerous circumstances, and the teachers and counselors at the schools have been able to flag teens that they had no idea were in trouble and provide immediate help. And the other thing that we hear from a lot of our teens is how much more they appreciate their parents after they understand the job of parenting so much better. And with that appreciation, they're going home and thanking their parents. And that's just strengthening the communication within the family, reducing tension and stress, which is great for everybody. So we're really happy to know that beginning to invite teens into this process and prevention has so many other effects to help people in the community. Next. So now I'm going to pass the baton to Lashima to bring it all home for us and provide a summary.
Thank you, Randy. So we thank you for your time today. And so as we wind it down, we want to ask you questions. So as we talked about ACEs, racial equity, and engaging some new faces in our prevention work, which new skills or approaches would you like to implement? When we think about implementation and what that looks like as we talk about ACEs, your agency, your program, you can be trauma aware and trauma responsive. And I like to make the point to say that this is not only for the clients or the communities we serve, but it's also internal work. It's important to support those doing the work before we ask them to do the work. So for example, one of our community partners really did an internal assessment and say, how can we better support employees if we're talking about addressing ACEs, our employees, our individuals as well. They may have had some experiences. So how do our policies and practices in our space even offer us an opportunity for those who may have experienced trauma who are our staff or employees to heal from that or to be in the best possible space and way to serve our clients. And that goes along with another, if we're talking about implementing skills or approaches related to addressing ACEs, it's important to foster a strength-based perspective. And that's in how we work with clients or individuals, but also in company culture as well. And utilizing that motivational interviewing technique that Randy talked about, that she's employed in Educate Tomorrow's Parents, I would say I've found that has been really wonderful with helping individuals be the leaders in their own. Our goal is to prevent these issues, but individuals are the leaders and they're the experts in their life. Parents are the experts for their children, and teens are the experts in their lives, especially in their minds, right? And so using that motivational interviewing helps them to be the leader in deciding what's best and what's next. And in terms of racial equity, understanding and the way I like to say it is that if you care about ACEs, you have to care about racial equity, because we know when we saw the example of, that pair of ACEs, a family or an individual planted in, some systemic discrimination might have otherwise had a wonderful chance, but those inequities and those systemic issues and, challenges and biases can really undermine an individual's opportunity to, or family's opportunity to, be successful and live up to their full potential. So making space to explicitly address racial equity in your process and your goals. If you get these slides, there's some links in the notes to some wonderful resources on what it looks like for an organization to address that. And we like to say an explicit, not exclusive focus on racial equity. And also that means inviting meaningful community participation as early as possible you can in program development. And that actually overlaps with, principles of trauma-informed care. It's just having those folks who are serving a part of the decision-making process in some capacity is important, and to do that as early as possible. And it's not after the fact, we realize, oh, well, we haven't had any community involvement. Make them a part of that process. And when we talk about engaging new faces, that's an example of that is developing cross-sector partnerships. It's really important, and it helps to fill in some of those service gaps where, frankly, if funding is short for a certain service, you can partner with other agencies to fill in that gap for the people we serve. And so that's been really one key thing to, I know the ACES Resilience Initiative is those cross-sector partnerships. And also when we talk about engaging new faces, maybe your agency, one thing that you'd like to implement is welcoming diversity and full inclusion at all levels of the program, offering a variety of perspectives. And that actually overlaps with being trauma aware, trauma responsive, or that trauma informed approach is having that variety of perspectives. The folks that we're serving, they're also a part of the decision making. And also engaging new faces, maybe you want to begin to engage teens in life planning and preparing for the family stage of life. As we think about effective ways to prevent ACEs, teens are in that really critical stage, as Randy mentioned, where they may have had some experiences because they've been parented, but they've not yet started their families, or they may just be beginning, and they have an opportunity to make those changes and decisions where their families have the best possible chance at a healthy future. So that's our presentation today, and we hope that you found some of this information valuable to your work and to help you accomplish your goals. And we'd love to hear from you. Our contact information is here. And I'd like to also add that Educate Tomorrow's Parents has curriculum available for your agency or for the work that you do. And Randy is also available for consulting. I know that I consult with Randy quite a bit. We're close partners in that. So she's a wonderful resource. And feel free to reach out to me if you're curious. There are other initiatives across the state. I'm happy to connect you with anyone that I know. If you're curious if there's a such initiative in your area, please feel free to reach out to me and I can connect you in that way. And we thank you so much for your time today. And that's our presentation today. And we want to remind you that together we are creating these healthy beginnings for all. And lastly, we want to thank you for being a public health hero.